Great, thanks Meg, Pedro, and of course Julio and the team for allowing this presentation. I'm doing this on behalf of a guidelines group hosted by IAPAC and very much in the vision of also contributing towards the 1990 goals. So it's the optimization of the HIV care continuum for adults and adolescents. I'm pleased to say that whilst this was the kind of cartoon that was drawn around the 2000 conference in Durban, we have moved on from this, and in fact the landmark change to that was the discovery of highly active antiretroviral therapy, and of course that has changed how we see the world. So wonderful opportunity in the last week to hear from UNAIDS that we did reach the 15 million goal, and truly this has in many ways changed everything around the world. I come from the part of the world where the burden of HIV is enormous. In my own country, treating everyone means that we will have to scale up treatment to more than 6 million people, and that is daunting. I look after a clinic in Gugulethu where there are 10,000 people that we've screened for antiretrovirals, more than half of them in care now outside and in the community. And whilst there has been this extraordinary emphasis, correctly so, to save lives, because indeed we have seen this wonderful extension in longevity in many parts of the region that I come from, the quality is now something that we cannot lose hold of, because we know that the treatment cascade is indeed a leaky cascade at the moment, and if we truly are going to reach that third 90, we're going to have to pay attention to that. How are we doing? Well, this is a publication that was seen in the UNAIDS GAP report that shows that, like many regions around the world, in sub-Saharan Africa, we have work to do in our cascade in terms of stopping that leakage. I'm pleased to say, and you've just seen from WHO and other agencies, we've really made strides to simplify the cascade. Many would have argued that when that cascade was as complicated as I showed you from just 5, 6, 7 years ago, it is no surprise that we found it difficult to do. We've now simplified it, but even still, there is work to be done on the cascade, and that is what has driven this decision to look at the literature and to try to come up with recommendations. We know that optimal healthcare requires working on the environment to improve effective health systems. We need to be talking to ourselves as healthcare workers so that we have a responsive system, and that we need also to have better education to our patients so that we have a more responsible patient population. And all of those three features come together to make optimal health outcomes. So in the guidelines that I'm literally going to take you through in the next 6 minutes, and expect you to remember all of them after that 6 minutes, we have looked at optimizing the care environment. We've looked at increasing HIV testing, increasing linkage to care, increasing treatment coverage, increasing viral suppression, and finally the metrics and monitoring that will be required. So to do this, a systematic literature search was conducted. A total of more than 6,000 studies met the criteria. This included RCTs, observational studies, and cross-sectional studies. The period we looked at was from January 2002 until July 2013, but also some recent game-changing papers, the kinds of papers that Gottfried was just alluding to. And out of that, 60 evidence-based recommendations have been put forward. And this has been consensus derivation from an international multidisciplinary advisory panel. The recommendations have also been graded based on the quality of the evidence, and this has given some strength to each of the recommendations that we've made. So I'm not going to go through each of them in detail, 60 of them, but I am going to just highlight aspects of them. In terms of optimizing the care environment, there are recommendations to remove the laws that criminalize certain key populations, that criminalize HIV exposure, to address issues of stigma and discrimination, to monitor for them and actively have them removed, identify and manage mental health issues, really promote the primary care platform and family-centered models of care, to look at this question of quality in an active way, both from the patient and the provider, and really have specific performance measures, to consider incentives for healthcare providers and clients, although clearly some of the data for that is still being strengthened and studies are ongoing, to definitely consider task shifting and sharing, to always underpin this with community engagement, and to promote patient self-management. Around HIV testing, again, in line with WHO, offer opt-out testing, to move testing into the community where possible, into the workplace where individuals are, and also to think about self-testing as an alternative to many who find it difficult to come to health facilities. To use epidemiological data to expedite those populations we should specifically be targeting, and to offer HIV testing to partners. This is my own interpretation, that we don't lose sight of the fact that we now have a prevention cascade as well as a treatment cascade, and we need to think about that as we improve the quality of our approaches. So in line with that, to promote immediate referral to HIV care services, but also to prevention services, to offer PrEP to individuals at high risk of HIV, as well as other prevention modalities, to involve people living with HIV as case managers and patient navigators where that's possible, and to link community and home-based HIV testing with those navigators. What about increasing treatment coverage? Well, again, wonderful, in line with great news from WHO that we offer immediate antiretrovirals irrespective of CD4, that it should be the safest antiretroviral regimen, that we embrace plasma viral load as the preferred monitoring metric, that CD4 is no longer recommended as such, although it may still be used within the context of OI prophylaxis, that drug resistance testing is recommended at entry into care when virological failure is confirmed. If unavailable, obviously, as it is indeed unavailable in many parts of the world, especially in the South, that population-based surveillance should then be recommended. And where possible, that we decentralize antiretroviral distribution. What about increasing retention? Again, systematic retention monitoring is required, we believe. Routinely monitoring adherence and using plasma viral load for that. Using technologies where possible, such as two-way SMS, now widely feasible around the world. Proactively engage and re-engage those patients who have left care, and have a return to care policy wherever possible. Increase viral suppression by educating and offering support for medication adherence and using tools to do that. Outreach and based directly observed therapy for particular populations, and again consider incentives, although those RCTs are still underway. Some recently data has come in. In terms of metrics and monitoring, again, consistent with the UN 1990 target, we have set out in our recommendations 4 indicators. First of all, that we should know the estimated number of people living with HIV, the number and proportion of those diagnosed with HIV, the number and proportion on ART, and the number and proportion virally suppressed. And that there should be longitudinal cohort monitoring of HIV services utilization and treatment outcomes, again, in keeping with the 1990 goals. There are some specific populations we have identified in the guidelines, particularly around women, offering community-based support and non-stigmatizing reproductive and parental counseling. My own passion that adolescents are specifically addressed, and that, number one here, that we remove adult-assisted consent to HIV testing, that adolescent-centered facility and community-based services are recommended, that we always inform adolescents of their HIV diagnosis as soon as possible and establish healthcare transition plans. Men who have sex with men are also there, and it's important to say that the sort of general recommendations that apply to everyone is across the board, but there are some specifics we've picked up on key pops, and clearly culturally competent care, education materials that address medical mistrust and other issues. Transgender individuals are also in our list of recommendations. And in particular here, something we've heard again from this community is that those who wish to start hormone therapy need to be referred to clinicians who know what they're doing. So we need to think about that in the context particularly of antiretrovirals. Sex workers are there, and there are specific recommendations, as well as substance users, and obviously harm reduction and comorbid psychiatric illnesses are also. Finally, migrant and unstably housed populations are another key population that we felt needed specifically to be addressed, as well as incarcerated populations. There was a great number of individuals who were involved in this process. Specifically want to thank the co-chairs, Julio, who led this, together with Renslow Shearer and Celso Ramos, but also the wonderful team at IPAC, particularly Emaine Sidibe, who did an extraordinary amount of work. And each of these individuals who read many of those 6,000 papers to come up with the recommendations. So thank you for that.